Thank you very much for inviting me, and we're going to switch gears a little bit because what I want to talk about is actually the function of the whole child, and there's two things I want you to come away with from this talk. One is the importance of the family in everything you do, and the other is the importance of refraction. And I'd also like to again extend an invitation to our joint meeting in Jaipur this coming December. I have no financial disclosures. So if we know that there's an estimated 19 million children below the age of 15 who are visually impaired, 12 million of these are visually impaired due to refractive errors. 1.4 million may have irreversible blindness, and those kids are going to need a lot more. They're going to need interventions for a full psychological and personal development, orientation, mobility, blind skills. Whereas the kids with refractive errors, guess what? They may only need glasses. We need to detect these children with visual impairment very early. Why? To identify barriers for them to participate in education, and to help the child and family access appropriate services and to minimize the effect of the disability. And to better understand a child's visual ability, we need to help quantify their vision beyond fix and follow or central study and maintain, which is what we'll write in our charts. Now, this is a child that we're comfortable examining. She's a little girl with ocular albinism. She's easy to refract. She speaks. She's 3 years old. She can sit in a chair. We know that she has adequate vision. She has good cognitive skills, and we know what to do with this young woman. But in this 3-year-old boy who has cerebral palsy, cerebral visual impairment, he's nonverbal, in a wheelchair. We can't use much of our equipment for him. He has poor accommodation. What do we do with this child? This is a child that can be helped with low-power hyperopic spectacles. In this case, his prescription was only a +3, not what we would normally consider to be that abnormal in a typically developing 3-year-old. However, this is not a typically developing 3-year-old. You have to think outside of the box. With this low-power hyperopic specs, first question we asked the mother, what do you want your child to do? She said, look me in the eyes. With +3 spectacle, he looked her in the eyes for the first time at age 3. So never underestimate your refraction. The family's going to have questions about not just what can my child see, but what can my child do with his sight. And in this case, this is a 4-leaf clover of the child's vision that you might be familiar with through the WHO. Vision is how children learn mobility to get around in space, how they learn daily care, toileting, how they do sustained near vision tasks such as eating and playing with their toys, and how they communicate with their family. So what the family really means in those questions is, can my child go to school with their peers? Does my child have functional vision but has other neurological or motor issues that he won't be able to use his vision properly, as an example would be cerebral palsy? Or does my child have profound visual loss with profound intellectual and motor disability and need different type of instruction? For example, a child with cerebral visual impairment. And these are mothers at a clinic in Chennai with their babies, all with cerebral visual impairment, who are learning from each other and a highly trained teacher on how to get their child to use their vision in a more typical way. Again, children are not little adults. Children with visual impairment develop functions and concepts based on a blurred image. We talked earlier about a child with a +7. Well, remember that +7 child with the microcornea and the lens implant has an additional at least +3 of presbyopia, so you're talking about a +10. They're going to have a blurred image, especially if they never get their glasses. Children also never experience a loss if they have congenital blindness. They never knew what they were missing. An adult with visual impairment experiences a loss, and they often already have a visual memory. This is one way we might be able to get to the children earlier. This is a nice poster developed at Aravind Eye Care System, and this shows the developmental milestones for vision in a baby. If something like this were placed in areas where the mothers go, or the carers go with the baby, this may help us identify children earlier. In this case, at age 3 months, the baby should be looking at mommy's face. Here at 9 months, picking up objects. And you can just march up the stairs here up to age 3. Very easy cartoon. The other children who need to be examined earlier are those that are at high risk for visual impairment. Any baby with a developmental delay. Unfortunately, our babies who have cognitive or intellectual disabilities often aren't picked up in the first couple of years. The same with cerebral palsy, and autism spectrum also may not be identified until age 2 or 3. These kids are all high risk, as are, we know, children born premature with or without retinopathy of prematurity. Now, we know that ROP protocols are for screening are developed regionally and applied regionally, but typically if there's no ROP, there's no follow-up for the visual abilities of many of these children. Many with ROP can be lost to follow-up once discharged, and again, those with additional visual impairment or ocular conditions may be common even without ROP. So visual impairment in children is not just related to visual acuity. It can be due to anterior visual pathway disease. This is what we're much more familiar. Or it can be cerebral visual impairment, which is posterior visual pathway. And if you just think of CVI being posterior to the lateral geniculate nucleus, which is right here, it gives you a better idea back in the optic tracts and radiation, occipital lobe, up into the temporal and parietal lobes, and also into the executive functions in the frontal lobes. Children's services need to be different than adult services. They require very complex multidisciplinary resources and need to be family-centered. We train the family how to do the intervention. We don't do the intervention to the child. The child's a developing young being. This is a case where we use what we have. This was in Nigeria. This is a cardboard box. We're teaching the mommy how to roll the balls in the box so that there can be a sense of sound and time and space. The earliest intervention is to teach the child to use the residual vision. Many of these conditions we're not going to cure, but if we don't use it and train for the residual vision use, they're not going to learn how to use it. And remember, play is the child's work and toys are the child's tools. We can also use things such as face, touch, talk, movement, all in a play type of environment for our children to begin their learning experience. The other thing I really want to emphasize is that cycloplegic refraction with appropriate prescriptions of glasses in all children is extremely important, including those with low vision and visual impairment. Often these children are thought nothing's going to matter, why put them in glasses, so they don't get a good refraction done to maximize their vision. You need to make sure when you're doing this that the child is comfortable and supported with good head support. And you need to document that there is a difference in whether you put the glasses on or not. We actually have a trial set that we'll put on the baby, and we'll actually do some evaluation to see if it's going to help them with facial recognition. It's one little trick. We know we use glasses for accommodative esotropia, significant refractive errors, to treat amblyopia and anisometropia, but often we don't measure accommodation, again in children with low vision and cerebral visual impairment. You need to measure the accommodation, you need to treat it. Often these kids can be on medications, anticholinergics that further interfere with their focusing ability. The other uses for glasses in children with low vision include magnification. We also use thick frame lenses for kids who have sensory issues and ADHD. It kind of acts like a blinder. It also gives protection from injury, and children with low vision are at high risk for injury. And as you know, transition lenses are tints for photophobia. The questions that families need answered are, what are the glasses for, so that they're encouraged to keep the glasses on the child. If they don't understand what the glasses are for, they may just think they're another prop and they have too many other things to worry about. So remember, the goal of pediatric vision rehabilitation is to maximize function of the whole child. The earlier the better. Why? To enhance educational potential, increase independence and quality of life, and this should be applied for all children regardless of abilities. Thank you very much.